Yeah, so we are at least already 12 people, so that's actually enough to start. Yeah, okay. So Rafa and Victor, again, thank you very much. And I know you don't need an introduction, but I will still introduce you because maybe somebody in the group doesn't know you. So Rafa is attending cardiac surgery in Pamplona in Spain. And he's also the Secretary General of the European Association of Cardiothoracic Surgery. And Victor Dayan is an attending cardiac surgeon in Montevideo, Uruguay, and he's the current president of the Latin American Association of Cardiac and Endovascular Surgery. So yeah, thank you. We are really happy to have you here, and thank you for taking some time from your very busy schedule. And yeah, we are happy to listen to your talk. So yeah, go ahead.
Okay, so thank you so much, Mateo. Thank you for the invitation. I'm delighted to be here today among you and talking about this subject, the conflict of interests, which we talk so much about, and sometimes we don't know what it means or what we can do about it. So over the next few minutes, I will make a few reflections, and it would be good if we could have some interaction. And I know sometimes people don't want to interact, but it would be good if we can, because there are many of the things that I will talk about are also a matter of opinion, and it's good to discuss about these matters. So conflict of interest is not new. It's been among us for a long time. Already in the Bible, it is clearly said that no man can serve two masters, for either he will hate the one and love the other, or else he will hold to the one and despise the other. You cannot serve God and Mammon in that time referred to wealth or money. There are many definitions of conflict of interest, and over the last few days I've read quite a few of them, and this is the one which I think is simplest and describes conflict of interest in a better way. And it says that it's a set of conditions in which professional judgment concerning a primary interest, that's patient's welfare or validity of research, etc., tends to be unduly influenced by secondary interest, such as personal gain. So we have here our own interest, our private interest, but also our professional duty. And there are two words here which are very important. It will be coming up over the next few minutes. One is judgment, and the other one is interest. Those are the two main words when we talk about conflict of interest. Now, there are a number of private interests. The one which we most commonly talk about are financial interest. Whether I receive consultancy fees from a big company like Medtronic, Edwards, or Abbott, whether I get paid for speak other events, their courses or other meetings, or whether even they support me to attend a course. And if it's a private company funds me to attend an annual meeting, or even a course that they might do. There are other interests. There might be academic interest or professional interest. We all have to produce some research. We have to write papers, possibly in a high impact factor journals, in order to progress, not only as academics, but also in our professional life as surgeons. You have to be seen. You have to be seen that you present at meetings, etc. So these are the private interests. And it's good to have private interest. We all have interest. If we didn't have interest, then we probably would not progress. If I didn't have to write papers or be involved in research, I would not progress. None of us would progress. So it's good to have interest. Okay, so this is not a bad thing. But we also have professional duties that we see ourselves every day. Even, you know, we have to do a simple article replacement. Now we have a number of choices to choose in prosthesis, for example. Why would we use the one on the left and not the one on the right? If company A, which manufactures the one on the right, pays me to go to a meeting, may I be inclined to use that one? We might be involved in a research project, and I may be given the task of designing it, choosing the two arms of a study. If we are comparing two treatments, who chooses the control arm, for instance, and what is that control arm? If I am an associate editor or a reviewer for a journal, and I get a paper to review, and I have to decide whether it should be accepted or rejected. My judgment should be clear for this. Or even more so, if we sit in a guideline task force, if I sit in the task force to write for instance, the valvular heart disease guidelines, I have the professional duty of being honest when I propose recommendations. So it's the balance between our personal interest and this professional duty or obligations, which is the important matter here. And there's been plenty of studies about how does mainly financial, because that's what mainly has been studied, interest affect our judgment. This, for instance, this is interesting. So these authors, what they did, they look at a number of publications, studies, they were all studies, trials, among different surgical specialties, cardiac surgery, general surgery, orthopedics, etc. And they look at the financial conflict of interest disclosed by the authors in that paper, and also what they have disclosed in their open data system in the US, and many of them were not concordant. Anyway, they found that any financial conflict of interest, whether disclosed or not, or relevant or not relevant, significantly influence whether studies report findings favorable to industry. And this is a fact, and this is not the only study. There are a number of studies showing the same, that we are all influenced by conflict of interest, mainly the ones which have been studied, as I said, are the financial ones. Let's look at this example, and I know that Victor will go through a number of studies in the past, but I think this is something which reflects well what we're talking about. I don't know whether you're familiar with Duragraft, whether you use it or not. If you don't know about it, this is a physiological solution which is used to store the grafts, mainly vein grafts, from when they are harvested until they are anastomosed to the coronary arteries. And it's got also some other components, antioxidants, arginine, etc. This is a product which has been in the market for a while. At least in Spain, it costs over 800 euros the shot. This paper was published in the BMJ, so it's a journal with plenty of reputation. And this is a paper about the rationale and design of a randomized multicenter trial that they had embarked. Now, first in here, let's see the two arms that they are comparing. So the treatment arm is the Duragraft, but the control arm, they say, is the standard of care. And this is heparinized saline. Now, I've come to know that I think this is what you probably use in Leipzig, but we don't use this for a long time now. And look also at this, look at the date. So this paper was accepted in March 2018. Now, according to the clinicaltrials.gov in the US, the completion date was August 24, 2017. So they actually published the paper, the design and rationale for the paper, a year after they had finished the study Now, the problem is that no results have been published to date, as far as I know, and I've been looking for them. So this already tells you something. Have they now found positive results, and that's why they are not publishing? This is a published bias. But what I was telling you about their control arm, which was heparinase saline, there has been a number of studies in the past comparing different solutions to preserved conduits. And this is one. This is not related to the Durgraph. But look at this. This particular figure is looking at cellular viability assays. So it tells you which of these solutions preserves cells best. And the worst by far is the saline. So what I'm trying to say is that they are comparing their product against the worst of the possible controls. And they might say this is a standard of care, but although in many hospitals they might still use heparinase saline to preserve the conduits, we know, and we've known for a long time, that this is the worst of. This is Plasmalite, which is a buffered solution, which yes, is much cheaper and is significantly better than saline. There are other many products. I'm trying to use that they're already choosing the control product, which is the worst of the possible control arms. And look at this other important information about this paper. Look at the contributors. So you have these people who designed the study, these people who drafted the manuscript. And look at this. So NYE and LPP are consultants for Solution, which is and they actually designed, at least one of them designed study, but TG is the chief medical officer. He's already designed the study and drafted the manuscript. And the whole thing was funded by the company. So you can see here how many interest and conflict of interest can be, and how this influence may have affected the judgment of those making the choices for the study. So when we talk about conflict of interest, we look at an individual, could be me, and I have to make a decision. I have to make a decision whether to choose one valve or another. I have to make a decision whether to use which treatment for my control arm, whether to reject or accept a paper, or whether support one or other recommendation for a guideline. And here there is an interest, maybe my personal interest. And we define interest as any influence, loyalty, concern, emotion, or any other feature in a situation which makes my judgment for this, my judgment, less reliable than it would be normally. And that doesn't make me more incompetent, but this interest is affecting my judgment for this occasion. And when we talk about judgment, it refers to the ability to make that decision in a correct way, more often than someone who has the surgical book, and can read all the rules and have the same information. That judgment gives me an ability to make a more correct decision than that person, because judgment brings knowledge, brings skills, brings insight, brings experience that someone who is not in a position will not have. And when we need judgment to decide on something, different decision makers, even though equally skilled, they might disagree without being wrong. And this happens very often. When you send a paper for review and it is rejected, you firmly believe that it should be accepted. And both, probably the reviewer and yourself, are equally capable. And probably both of you are right or wrong, but you are not happy normally with the decision. Another important aspect is that I cannot have an interest without knowing it. I might say, well, yeah, they pay me to go to the STS last year, but that's not affecting my judgment. So I can misjudge how much it does, but it does affect my judgment. If I have an interest, it affects my judgment. if someone who is asking me to review a paper, someone who is asking me to design a trial, someone who is asking me to work on recommendation for a guideline, if that person doesn't know that I have a conflict of interest and I don't tell them, I will allow them to believe that my judgment is reliable when it is not. And I would be deceiving them. I would be lying to them. And that is morally wrong. So it's my duty, first thing, to disclose my conflict of interest, because otherwise I will be lying to those who trust me for those duties. But even if I tell them that I have a conflict of interest, if I disclose them, that doesn't make me more reliable for that judgment. Still, I'm not as reliable as if I didn't have a conflict of interest. And what can we do about conflict of interest? What are the options? If I'm conflicted, as I said, most of us, if not all of us are, well, we can escape. We can say, listen, I'm sorry, I cannot review this paper because I'm conflicted, because they are comparing two treatments and I've been involved all my life. I've been involved researching one of those treatments and my judgment is not reliable, is affected by that. And that's the best solution for conflict of interest. I can disclose it, and we should always disclose it so everyone else know that my judgment is affected. So they know, oh, whatever he says, be careful because he's conflicted. So I will not be lying to them. And also we can manage them. So say, okay, he's conflicted. His judgment might be as reliable as we might think. Let's look for a second opinion. Oh, okay, if we are in a task force for guidelines and we have to vote for a recommendation, if you have a conflict, you don't vote. So there are different options for this. Now, this is quite very busy slide, but this is just an example of how the European Society of Cardiology deal with financial conflict of interest. So these are the instructions for those who might be members of guidelines, task force or committees, expert writing committees or scientific task forces. So you cannot be part of any of these task force or committees. If you receive direct remuneration for the development of that guideline, imagine that Medtronic comes to me and said, okay, if you manage to be in the task force for the heart valve disease guidelines, I'll pay you 20,000 euros a year. No, I cannot do that. Or if I've employed or own shares of one of these companies, if I hold the patent or some intellectual property, so I could not be part of any of those bodies. There are other conditions which would not stop me from being part of those guidelines, like receiving consultancy fees or speaker fees or participating in steering committees of clinical trials, but I should disclose them before every meeting. I have to say, listen, I get 10,000 euros a year from this company on consultancy fees. So everybody knows that you're conflicted and that your judgment is affected. So these are some of the rules that ESC follows. And this is the rules they follow for the chairs of these task forces. If you are a chair, you cannot receive more than 10,000 euros a year, either personally or through the institution. I mean, this is just an example of how could you manage that conflict of interest. So this is the last slide. As I said before, there is a balance between our personal interest, our investments, financial, career, etc., and our integrity as professionals. And we have to be aware that conflict of interest exists and that conflicts, one way or another, to greater or lesser extent, will affect our judgment on our professional duties. That's all what I wanted to say. If there are any questions or any comments.
Rafa, yes, I do have a question. I mean,
yes.
Boss, Michael is also there. Maybe you can start, Michael, if you want. I can do my question afterwards.
No, go ahead, Matteo.
Oh, well, it might be a provocative question, but I am interested about that. You mentioned we all have different conflicts of interest. It's part of it. And as you know, the editor-in-chiefs of different journals, they are very powerful actually, because they have in their hand the decision whether to publish or not something. They can even decide if they send something for review or not. So how is the case in the European journal? How do you guys manage that in terms of choosing who is the editor-in-chief and what kind of conflicts of interest he has, and how does that work? Because I mean, that's one of the more influential journals in the cardiac surgery world, and he has a very powerful position deciding what comes out and what not.
So yeah, Mateo, that's an interesting question. And it's true that editors-in-chief had lots of power. The editor-in-chief of the European Journal of Cardiothoracic Surgery is not as powerful as the one of the New England or Lancet or Circulations, and they are very well paid for those positions, and the editor-in-chief of our journal does it for free. How do we choose them? Well, there is an open process, an open application process, and you look at their background, they look at what they have done, they look at their experience as reviewers and associate editors. I don't know whether you know it, but at least in the European journal, every time you do a review, you are marked from 1 to 10, and whether you review on time, whether you review with the editor, associate editor feels that your review is balanced, and they look at that kind of thing. So it's those people who have a very good reputation who then are look for higher positions and eventually editor-in-chief. How they do it in Lancet or other journals, I don't know, but there are always people with very good reputation. But I agree that their position is sometimes can be compromising and difficult when they make that kind of decisions. Yeah. And remember, it's normally the associate editors who reject or accept papers. So it's rare. I'm sure it happens that the editor-in-chief at the end of the day look through all of them, and if there is something which say, oh, this is how unusual, then they can take action. But in my experience as associate editor, the editor-in-chief has never told me why you have not accepted or rejected a paper.
Rafael, maybe I can ask a question, and I apologize, I came a bit late. I thought we were starting at 5 o'clock and got mixed up. But I caught the second half of your presentation. It was excellent. Just one quick comment first, because I know from, working on the upcoming endocarditis guidelines, so I'm one of the 2 chairs, they are going to change the rules next year for ESC that all of the writing members are going to be limited by that $10,000 or euros per year, which I think is completely appropriate. But it's going to probably reduce the number of experts available. And this is the comment that you always hear, like, oh, well, then the experts aren't going to be able to actually participate. What do you have to say to that?
Yeah, and I agree, that's interesting. And that's what people are talking now. Some people are talking about confluence of interest rather than conflict of interest. And how can you manage them? And obviously, if you're an expert, you will probably have more conflict of interest with industry, for instance, and if you are not. And also, I mean, if they say, as you say, if you have more than 10,000 euros of income from industry, then you are barred from serving any task force or writing committee. That's going to make life difficult. But they also look at you, and you, whenever you are offered or you have the possibility of having some kind of funding or reward, you say, no, I don't want any of that, because that could prevent me from serving in interesting things like that. So I think that also goes to the person. I said, at the end of the day, you're going to have a choice. Do you want to receive consultancy firms from these companies, or do you want to be able to serve guidelines writing committees and on task forces, etc. But how to manage that? How is difficult? And I agree, as I said in my talk, we all have conflict of interest which will affect our judgment. Whether we like it or not, it will affect our judgment. And you don't want people in taking these important decisions who have their judgment affected by that kind of conflicts. Whether it will make better guidelines or not, I don't know. But that's it.
Yeah, and another option that they're looking at, which they've already basically implemented, is that at the beginning of the guidelines process, everybody has to say what their conflicts are. There's a half hour where everybody's conflicts are shown separately on a slide, and anybody who has a question or an objection to somebody else's conflicts can discuss it there and then. But then people can also, they will be identified as people who are not allowed to vote on certain aspects, which I think is also a reasonable option of still having experts involved on the decision-making process and on the argumentation that occurs in the groups, but they can't vote. If they have, got 100,000 euros last year from some TAVI company, then they don't vote on TAVI, which I think is absolutely also reasonable.
So that is, I agree with that. But for instance, we are now going, and I'm reviewing the conflict of interest of those involved in the task force to review the left main stem guidelines. And we are just going through, myself and Colin Bejen, through them and the conflicts. And do you have people who have receive consultancy fees well in excess of that, but from companies and business which are completely unrelated to the subject of this review? How does that affect their judgment? I don't know, and that's for us to decide. Well, I don't think that will affect his or her judgment, and so that is one point. And as things stand now, every meeting, those with conflicts will have to disclose them. I said, I received so much from this company and so much from this company. Now, and I agree, and we do that they cannot vote. But there again, if I'm in a task force, Michael, and you are voting for, and I know because we're discussing what you think, it's very unlikely that I will go against the judgment of Michael Borger or Alec Bahanian or Frieden Beyersdorf, or so that also, I don't think that not having them to vote does not remove the conflict, because I've seen that. Normally the leader of that side, normally the chair, in the discussions, we all know their views, but then they cannot vote, but everyone else in their part know their views. So that's a bit, although it's good, it doesn't resolve the problem completely, I don't think.
Can I ask you just one more question?
Yeah.
I'm sure you've been shocked, as I have, some of these big cardiology meetings where they have 2 seconds to show their disclosures. It's actually timed. It's timed into their presentation. The slide automatically changes after 2 seconds.
Yes.
But the whole slide is full. They basically have gone to this strategy of declaring everything to make them completely innocent. And I don't know, that's kind of making a farce of the whole process, isn't it?
It does, but the thing is, from my point of view, is at least they are not lying to me. They are telling me my judgment is affected. So be aware. That means that now I know what you are saying is not necessarily true, or it's not balanced view. That's all. But the thing is, these people, we tend to believe them anyway. We tend to think because they are experts that they must be right. But they are not. We are not saying that they are not good, but they are conflicted, and their judgment is affected by the conflict of interest. I mean, we discuss this often with Victor as well. Some of the papers, the disclosure of conflict of interest is longer than the abstract itself, many of them. And that's the minimum they can, but what they are telling you, as I said, is I am conflicted, my judgment is altered. So be careful with what you read. And that's, we're just talking about this before we started, is that now we have learned to look into the small print of all the trials and of the study, going into the appendix and looking at the real data to make sure that they are not deceiving us. I mean, and this is just my last thing, Matteo. Just looking at the recent individual patient data meta-analysis presented in the AHA on the left main stem, looking at the 4 main trials. Now, the primary outcome in all 4 main trials, the pre-combat, syntax, Nobel, and Excel, the primary outcome was a composite outcome of death, myocardial infarction, revascularization, and stroke. And that's what all 4 studies were powered for, to find differences for that primary outcome. Nowhere in the main paper of the individual patient data meta-analysis paper that the result of the primary outcome is found. It's hidden. It's not there. You have to go to the appendix to see it. And that's an example, but that happens all over the place. And I think Victor now in his presentation is going to show us quite a few examples of that.
Hi, I just would like to step in and add a little an issue regarding what Michael asked. Hi, Dr. Borger, my name is Victor Dayan. And regarding the first question about, this is an issue that I have read and heard a lot come out regarding if you put a ceiling of 1,000 euros for all the writing committee members, you will get a few experts writing the guidelines. So, and I always get into a fight with this stuff, with people who say this, because I would like to know what's the definition of expert. So is the definition of expert the surgeon or the interventional cardiologist who published the most or published a lot on the subject, for example, published a lot on TAVI or published a lot on the issue at hand? If that's the definition of expert, wouldn't it be best not to have him in the committee and have someone who could objectively analyze the data who was produced by this conglomerate of co-authors, because we have a conglomerate of co-authors who always publish and have a very high H index, because there's a lot of friendship and associations. So I believe, and I have worked a lot with members that are not considered experts because they do not have that high in number of publications, but they are experts in their capacity to analyze the data from those papers. So maybe the definition of expert, I believe most of the people who have conflict of interest and with this new imposition would be driven out of the writing committee are the most who are trying to grasp and not to release that. What for me it's an ancient concept of expert, because if I publish an article, if I publish a paper or an investigation of something, and I am invited to be in the guideline committee on this subject, I will defend what I found, and I will be totally biased on that. I will not hear very objectively what you have found, which was against or in opposing directions, and I will not analyze objectively the data from your side. So I believe maybe this issue of expert needs to be a little bit more reconsidered in these circumstances, I think. So, I don't know.
You have a presentation though, Victor?
Yes. If it's okay, I can go ahead and I will go quickly in order to, for sake of time. Okay, so my presentation is, the intention is to be centered on the issues that need to be grasped. It was a presentation intended mainly for residents. So Dr. Borger will probably find this a little bit boring, but it's the issues that I believe that residents should be very aware of and should try to dissect in trials when analyzing the validity of the outcomes and the results and the potential bias behind it. So the presentation is clinical trials in surgery and bias knobs. So I was trying to look at the definition of knob and not a bias knob, because there is no such definition in the Oxford Dictionary, and the knob is defined as a way of addressing or referring to a person that you think is very stupid or unpleasant. I think this was not the definition that I was looking for. This is more like a more sound definition, a round handle or a small round device for controlling a machine or electrical equipment. And this is what I believe should be the definition of bias knobs, the methodological armamentarium that investigators have to control the validity of a trial. So what is the main difference between surgical trials and non-intervention trials? The main difference between these is how to control for the placebo effect. Surgical trials and intervention trials, or surgical, when we compare surgical and intervention, the main limitation that we have to the analysis of the outcome, and depends on which outcome are we analyzing, is how to control for the placebo effect, and therefore how to control for what is called ascertainment bias. So let's have, for example, this is a trial that's called the SHINE Chronic Total Occlusion Trial, which is sponsored by the Minneapolis Heart Institute Foundation. It's a double-blind sham-controlled trial, double-blind in the sense that neither the patient nor the investigator who will draw the results from the patients know to which arm the patients were randomized, and in which the main outcome is a 7-item CDUC angina questionnaire. And then we have this trial, which is a very similar trial. Both trials try to assess the benefit of chronic total occlusion revascularization through angioplasty versus optimal medical treatment. And in this trial, this is the difference is that this is a prospective randomized open label trial. It's exactly almost the same in its design, with the exception of this open label. When we talk about open label, is that there is no way, there is no blinding. The patient, the investigator, everybody knows to which arm was the patient randomized. And the primary endpoint is composed of two cohorts, cohort A, in which there is a composite endpoint of major adverse cardiovascular events, and cohort B, in which you have the CTL angina questionnaire, quality of life. The number of patients is totally different. For cohort A, you need 1,200 patients. In cohort B, you need 360 patients. We will check again these issues in a little bit later on. So what's the difference you can find between both trials? And this is like, this is a presentation that I did in Spanish. Feos in Spanish means uglies. So it's like an thing that is a little way, is a way to, in order for us to look quickly at the issue, at capital issues when you are comparing the two trials. And it's finance, blinded, main outcome, and bias. And if we compare the SHINE versus the ischemia trial, the SHINE trial is blinded, while the ischemia trial, the ischemia chronic total occlusion, it was not blinded. The main outcome in SHINE was a questionnaire, it's a subjective outcome, while in the ischemia chronic total occlusion, you have two cohorts, one which is a subjective outcome and another one which is an objective outcome. And I will talk about subjective and objective outcomes because that's a capital difference that drives the importance of blinding in a surgical trial. So in the ischemia chronic total occlusion trial, you have what is called ascertainment bias, because since you do not have blinding, the investigator who will drive the results from the randomized patients already knows to which treatment was that patient randomized, and therefore you could have bias in the collection of the data. But that's specifically for cohort A, sorry, for cohort B, not for cohort A. When you have the outcomes are of what it's called hard outcomes like death, stroke, acute myocardial infarction, blinding has a very, it's not as important as it is important when your primary outcome in a trial is a subjective outcome like quality of life. And here you have what is called, what we already know, which is the CURAGE trial, which the primary outcome was all-cause mortality or non-fatal myocardial infarction. And the secondary hypothesis and the secondary outcomes was the resource utilization and quality of life comparisons. These were the results of part of the results of the secondary outcome for the COURAGE trial. And if you see when they describe the results, they mentioned that the requirement for neurovascularization was performed at the discretion of the patient physicians. So the COURAGE trial, if you might remember, is an open label trial. There is no blinding. The physician to which the physician which will define if a patient needs or not a new revascularization already knows the revascularization, the treatment arm to which that patient belongs to. So therefore, that physician is under the influence of what we call ascertainment bias. And therefore, if the physician has a patient that went to optimal medical treatment and starts with chest pain, and he knows that he did not receive a revascularization procedure, he might be inclined to be more easily in ordering a new revascularization compared with a patient which he already knows that he received a revascularization because he was in the revascularization arm. And let's see what happened. There was no difference in the main outcome, which was the heart outcome. That outcome, the solid heart outcome in which there is no influence with blinding, which was a non-fatal myocardial infarction or death. But there was a difference in this outcome, which was subject to a certain bias, which was new revascularization. So that was the COURAGE trial. Now let's see what happened with the ORBITA trial. The ORBITA trial was very similar to COURAGE trial. You might recall that patients were randomized to optimal medical treatment or to PCI. Of course, there were differences in the number of vessels involved, but the main difference is that there was a quadruple blinding. The participant, the provider care, the investigation, and the person who defined the outcome were blinded to the treatment arm of that patient. The primary outcome was a subjective outcome, which was exercise capacity. So here we have what it's a perfect design in a surgical or interventional trial, in which when your primary outcome is a subjective outcome or a soft outcome, such as exercise capacity, which might be influenced by ascertainment bias, you need to have what is called a double blind or quadruple blind design. And let's see what was the result of the ORBITA trial in which there was blinding as compared with the COURAGE trial in which there was no blinding. In the COURAGE trial, has shown that even in patients with severe coronary stenosis, exercise capacity and symptoms are not improved significantly compared with a placebo intervention. So in this trial, in which everyone involved in the trial were blinded to the treatment arms, and therefore in which the primary outcome was a subjective outcome, the primary outcome found no differences between both treatment arms. And now let's see, this is a recent trial that got a lot of heat in the social media, which was recently published at the European Heart Journal. And it was a retrospective study, it was not a prospective trial, in which early invasive coronary angiography and ischemic heart failure outcomes were assessed in patients in which were admitted with acute heart failure. These patients were admitted with acute heart failure, and some of them underwent early coronary angiography, and some of them didn't. And what the investigators evaluated were the outcomes, the all-cause mortality, cardiovascular mortality, and hospital readmissions after 2 years. What they found was that patients who were directed to early coronary angiography had less all-cause mortality, cardiovascular mortality, and hospital readmissions. Now, so for the residents mainly, do you find any selection bias in this study, which was published in the European Heart Journal, which is the journal with the highest impact factor in cardiology? Of course, there is a huge selection bias, right? So, and this was a study very heavily criticized by our David Brown, who you might everyone might know him. The selection bias, just for the residents in this case, is evident from the conception that patients more susceptible and more fitting to go to early angiography would have undergone early angiography, while patients which were much more ill and not so fit to go to early angiography would have been denied or taken another route. And that would have explained the main outcome between these two treatment arms. So the only way to avoid selection bias is randomization. Now, is randomization enough? So this is like a very simple diagram just to show what's the direction of the path in a clinical trial. You have the the recruitment, then you have randomization, which can be simple or in blocks, permuted blocks, and then you have the treatment. So first, randomization avoids selection bias, and then from the randomization allows, according to the randomization technique, you have what is called the possibility of allocation bias. And let's see how can you still have bias even though you have randomization. One of the techniques of doing randomization, it's simple randomization, in which it's like flipping a coin. You just get that patient goes to treatment A or B, A or B, A or B, A, B, B, whatever. Or you got another possibility is having block randomization. And this is mainly in trials in which you have a small number of patients and in which you want to be sure that you have a very balanced treatment arms on both sides. If you have, let's say, 30 patients and you make simple randomization, you might get 15 on one side, 15 no, but you might get, let's say, 8 on one side or 9 on one side and 6 on the other, and there might be differences in basal characteristics. Therefore, in block randomization, you establish a number of clusters. Clustering is not the perfect way because you have cluster randomization, but let's say a number of boxes in which in each box you have 4 possibilities or 4 different possibilities of treatments. And let's look at this, for example. If we have a treatment which is the treatment purple and another one which is the treatment red, and we make a block randomization of 4 in which we get groups of 4 and in which in each group we randomized for each of the slots, we might get for the first slot of the 4 void block, the purple treatment. Our second randomized might be red. Our third randomized will be red as well. And our 4 possibility, we already know which of the treatment he will receive. Because since in the block randomization, you have 4 possibilities, and you already know that in the 4, you will get 2 red and 2 purple, the investigator who will recruit the next patient knows that the next patient will be assigned to purple. Therefore, allocation, what is called allocation concealment, is extremely important in this type of block randomization. Or another way to do it is to do different number of blocks alternatively. You could have blocks of 6 slots, blocks of 4, blocks of 8, and not having the investigator know how many slots are in each block. The concept here is that doing a randomization only does not assure that eventually the investigator may have an influence on knowing which of the treatments might be assigned to the patient. We need to go deeper on that and see what type of randomization technique was performed. So here is what is the ischemia trial, which we already know. It is an initial invasive conservative strategy for stable coronary artery disease in which patients were randomized either to revascularization or to optimal medical treatment. Among the revascularization patients, 79% underwent revascularization. Of the revascularization patients, 74% underwent PCI and 26% underwent CABG. This was the primary outcome of the primary composite outcome, which showed no difference. Now, is it valid to compare CABG versus optimal medical treatment and PCI versus optimal medical treatment? Can we ask the investigators to release this data? Can we ask them to publish, okay, show me what were your results for the primary composite outcome of PCI versus optimal medical treatment and for CABG versus optimal medical treatment? So this drives us to another issue, which is called stratification. And in my personal opinion, this was a major issue that was missed and was not performed in the ischemia trial, while on the other hand was performed in trials like partner trial, for example, as we will see. It's an additional mechanism to assure balance. It needs to be performed before randomization. And as the FDA mentions, stratified randomization is also used when the magnitude of the treatment effect is expected to vary among important groups. So how would have I designed the ischemia trial? I would have designed where the patient would have been recruited. Stratification would have been performed to either CABG or PCI. What does this mean? Once we recruit the patients, we will see each patient in the heart team, see the coronary angiography, and we would agree between the patients, among all the heart team members, that this patient can either go to CABG and PCI, and then we will assign them aleatorily to either of these groups. And then that patients would be randomized to optimal medical treatment or to CABG. So is it valid to compare CABG versus PCI? So, sorry, before this, in the ischemia trial, this stratification wasn't performed. Patients were directly randomized to revascularization or optimal medical treatment, making comparison between CABG and optimal medical treatment impossible or not methodologically valid. Why was not that performed? Maybe that's one of the bias knobs and one of the ways in which investigators may divert or have an influence in the outcome of trials. Now, once we can compare in a stratification randomization CABG versus optimal medical treatment, but can we compare CABG versus PCI? So let's have an example. This is the partner 2 trial. This is the diagram of randomization that they performed. They recruited the patients and they assessed for the feasibility of transfemoral access. If that patient had possibility of transfemoral access, they went to the transfemoral arm and they were randomized to either TAVI or surgery. And if that patient did not have feasibility of transfemoral access, they were randomized to transapical or transaortic and surgery. So this is what we call stratified randomization. And these were the results. This is the result of the transthoracic access cohort. This is the result of the transfemoral access cohort. And let me please ask to the residents, do you believe that patients that were randomized to this group are the same, even though we are only looking at transfemoral access, are the same in the general, globally, as these patients that were randomized to transfemoral? Obviously not, right? Because peripheral arterial obstruction or peripheral arterial disease is one of the main issues in the Euroscore calculation, for example, and we already know that it's a surrogate for diffuse vessel disease, intracerebral vascular disease, and risk of embolic, stroke, and whatever. So these populations are obviously different, and this is what explains the results that we see. The transthoracic access had worse outcomes with TAVI versus surgery compared with the transfemoral access cohort. Even though if you see surgery had, and the primary outcome at 3 years, 42%, while in the transthoracic cohort, it had 48%. It was higher because these patients per se are more diseased. And therefore, what was the indirect effect of doing this type of stratification? It was making the transthoracic access look worse than it might have been if it have been performed in this group of patients. And this is the way in which the authors explained and mentioned in the discussion part of the results. A key subgroup analysis showed that the outcomes of TAVR through transthoracic access, but not through transfemoral access, were inferior to those of open heart surgery. If you look word by word, it might be correct, but the impression that you get is that for similar type of patients, transthoracic access is worse than transfemoral access, and that is incorrect. You can't compare transthoracic access with transfemoral because the methodology of randomized stratification allows you to compare the transthoracic with surgery or the transfemoral with surgery, but not each other across. And therefore, just to resume, when blinding is important depends on the primary aim. When there is risk of ascertainment bias, as we already mentioned. When do we have ascertainment bias? It's all that bias that arises after the patient is randomized. All that type of bias that happens or that occurs after patients are randomized. So if you have hard outcomes or primary outcomes, you do not need blinding. You do not need to have patients, investigators blind in order to know or to be influenced to define if that patient died or did not die. But you need blinding if your primary outcome has soft outcomes. So this is just only for my residents to explain what are hard, soft, and surrogate outcomes, which I guess you already know. And finally, the issue of composite outcomes, which is a very controversial issue, and which is an issue that allows a lot of manipulation on the final outcomes of a trial. What are the beneficials of composite outcomes? Fewer patients are needed. That's the most important beneficial effect. And if fewer patients are needed, trials would be cheaper than using an isolated outcome. Now, what are the adverse effects? The real benefit is diluted and subject to manipulation, and opposing direction of isolated outcomes make analysis complex. Less patients are needed. Let's see, if our primary outcome is objective mortality, and we expect this type of mortality in treatment A and B, we will need 14,000 patients. If we use a composite outcome and we expect 6.8 in treatment A and 12.4 in treatment B, this is the number of patients we need. So in partner 3, which has already been discussed a lot, we have a composite outcome, which is mortality, stroke, and rehospitalization, in which the primary outcome is mainly driven by rehospitalization, which is one of the main disadvantages of using composite outcome. You can have the primary outcome only driven by only one outcome, and if that outcome that drives the whole composite outcome is a soft outcome, subject to ascertainment bias, like in this case, that makes interpretations and validity of results quite controversial. And this is the case for the EACTS trial at 3 years, and this is how can we analyze the effect of a composite outcome when you have individual outcomes in that composite going in opposite direction. For example, in the EACTS trial, you have death that shows to be higher with PCI than CABG, but on the other hand, you have MI showing to be higher with CABG than PCI, and then you have a composite outcome that shows no difference. So how can we, even though methodologically and statistically it can be correct, but from common sense, how can we consider no difference in the composite outcome when you have the individual outcomes that make up that composite going in opposite directions? And last, this is a letter to the editor that I wrote to Jack regarding chocolate trials, regarding one paper published using time involved. And what I consider to be a definition of chocolate trials. When should we suspect a chocolate trial? Why chocolate trial? Because comparing the treatment arm of our new technology or our new treatment with a placebo or a chocolate would yield the same results as comparing it with the control trial, the control treatment, which the trial is currently doing. So when should we suspect a chocolate trial? When it's the frequent outcomes are used on one of the frequent outcomes that are expected to happen on one of the arm studies are used. For example, rehospitalization in patients with SABR is quite, at least in my country, is frequent to have rehospitalizations in patients who undergo SABR. So if you use that outcome that you already know that is very frequent in one of the treatment arms, you're doing like a chocolate trial. It's the same as comparing TAVI with a chocolate. And when the time of follow-up is not enough, if we are comparing only 1 year, our main outcome is expected to close at 1 year. Therefore, we are not given the time for our control of our best treatment at that moment to have its effect on longer term follow-up. So thank you very much for your attention, and I'm open to any questions or discussions that you might have.
Thanks a lot, Victor. Matteo, if I can maybe start, can you show that partner 3 Kaplan-Meier curve again? Yeah, it's number 36 there, yeah. So you said, Victor, that readmissions are common in your country. It's not just in your country, it's everywhere. And if you look at the top on the left, on the A frame there, And if you look at the top curve for surgery, you see that the majority of these events all occurred within the first month after surgery. And of course, we all know that's when patients come back for pleural effusion or for atrial fibrillation or something. And these are not necessarily life-altering events that are going to worsen their prognosis over time. So for the REPAIR MR study, which is comparing MitraClip to surgery in intermediate risk patients, myself and a couple other surgeons that are on the steering committee made sure that they put in a blanking period for the first 30 days after the surgery, that they could not count those as readmissions to the hospital. Because if you took them away here, you basically would not have seen any big difference between the two groups from my point of view. Just one more quick question though, the composite outcomes, we have to be really, really careful as surgeons as what gets thrown into that pool of composite outcomes, as in this example shows very well. And I think this is where, Rafael, we need to teach the young generations of cardiac surgeons interpretation and planning of trials, because we're in the OR all the time, we're busy and we don't have time to learn these things. And you're up against not only army of cardiologists that are not stuck in the OR all day, but also all of their help from the industry. And it's kind of a one-sided fight. But this is the most important part for us as surgeons to put the rules down, is right at the initial protocol development stage of these trials.
Yeah, if I can, yeah, I entirely agree with that, Michael. And if you look at different trials, and we have, for instance, EACTS, in which the choice of one of the outcome variables, which was pre-procedural MI, the one they choose in the very beginning, we all knew that was going to favor one of the arms, which was surgery. And it wasn't until we look into the data according to the universal definition of MI that we saw the difference. Also, another thing which is important, and I would also like to listen Victor's view in this, is when we talk about the choice of outcome variables, and first we have the VARC2, and now we have the VARC3. If you look at some of the definitions of VARC3 for instance, bleed, surgical bleed, and you may have just a drop in 3 grams of hemoglobin that is considered a class 2 or a class 3 hemorrhage bleed event, and that goes in the primary outcome. Now, many patients, particularly small elderly patients, by the fact that you put them on bypass because of hemodilution, they drop the hemoglobin. They might not need even transfusion at all, but they have not bled. But yet, because they have dropped the hemoglobin by 3 grams at some stage, that's considered like a serious bleed. There are things like that, and because it's a VARC2 or VARC3 definition, everyone thinks it's gospel, and we should be very careful with that. I agree, Michael, that we should be educated in the meaning of the choice of outcome variables to be able to interpret. And when we sit in steering committees, or we sit as a principal investigators or investigators in these trials, we should be able to say, hold on, I do not agree with that. But then those conflict of interest come in, because if I'm asked to be a co-author of EACTS, I will say, okay, I'm not entirely 100% sure of that, but I'll go with it. And then you become part of the problem, because you want to be a co-author of EACTS, you'll be all over the place. And that's where the conflict of interest also come in. And that, if you remember all the discussion with EACTS, they said, oh, but you have some surgeons who were there at the time, but didn't say anything about it. Probably they didn't notice, but yeah, you have to be careful. And now we look at the small print of all the trials and everything. And we should be educated on that. I entirely agree with that.
I think, Rafa, when it's nice because we are merging the two talks, right? You mentioned VARC3, and if you if we want to compare what's BARC3 and what are trials and what are guidelines, BARC3 is like the definition of outcomes that the trialist will then use, and which the guidelines committee will then take from the trials to promote guidelines. Now, what happens when you have the same people in these three instances? What happens when in the BARC3 definition, authors, co-authorships, almost all of the co-authors have relationship with the trials for which they made those definitions. And then they they go back to their trials and use the definitions that they made themselves, and for which, of course, they are conflicted with personal interest, right? So this makes issues much more important and much more dangerous than that at first sight it looks like.
Yeah. I have a question for both of you. It's not a statistical question anymore. It's more, let's say, a political question. There are actually two questions. So the first one is, for example, regulatory entities such as the FDA, for example. I mean, they are not idiots. They have statistical experts. They know all these tricks. Why do you think they still support some recommendations or approve some medications or devices or whatever they approve based on this kind of trials? Because they actually know the biases and the weaknesses of these trials. Do you maybe have any insights into that political regulatory world?
I personally have very, I'm not an expert in this thing, of course, but I think the FDA, in order to, Michael probably knows much more than this, but this is from the discussions and the debates that have been going on regarding the inclusion of TAVI in low-risk patients and the inclusion or not of TAVI and the inclusion of the COSIRA device of Greg Stone regarding the coronary occlusion device. And the FDA needs, I think it initially needed 2 trials in order to approve the device, right? And then the thing is that actually they're approving, this is, let's say, probably someone from inside the FDA might label what I'm saying as not being exactly correct, but this is what people from the US are mentioning, that they are using nowadays only 1 trial just to approve the devices. So this is, of course, a very important question. For the COSIRA trial, for example, this is something that I have presented previously, which is this coronary sinus device in order to patients who have no alternative for revascularization, either PCI or CABG, which was a trial thrust forward by Neovasc. The trial showed what you should call very, very soft outcomes, very positive soft outcomes, which was a quality of life or angina symptoms. But the FDA, the committee of the FDA, took those results, and they take results that we do not have access to, right? And they practically destroyed the trial, the outcomes, and that device has not been accepted yet. So I believe that there is some hope for additional analysis from the FDA, taking into consideration outcomes that we do not have access to, right?
Yeah, maybe I could also add on that, Mateo, because I know lots of people that have been in front of the FDA to present data. The FDA is, like you said, they're not stupid, but they invite experts, outside experts, to come speak to them. Of course, some of them are conflicted, some of them aren't, and then they weigh their decision. There have been some very good decisions, and there's also been some not very good decisions, but they also have their own political pressure, right? So TAVI was approved in the United States, 47th country in the world that got approval for TAVI, right behind Albania. And this was, for the Americans, a real bitter experience. They basically said, hey, how can this be that this life-saving technology for very high-risk patients is not available here? And there was a lot of pressure put on from the political side to fast-track some of the review processes and technologies. And this all happened while I was in New York. I was amazed. I was in Germany and we were doing all these first-in-man studies. And then all of a sudden I went over to New York, and then 3 years later I come back and all of the first-in-man studies and everything have stopped in Germany, because Germany has now become much more restrictive. BfArM has become much more restrictive than FDA. And now all of the big companies go to America first to get their approvals done, because the FDA is more lax. You know, they try to find that balance, Matteo. It's a difficult situation. It's not easy.
Yeah, and maybe one last question, Rafa and Victor, what are we doing from the cardiac surgery societies to fight this war, let's say? Because I feel the cardiology societies are very strong. They have a higher impact journal, their journals have a higher impact. There are more cardiologists than surgeons. And I mean, they are interested in all the different devices. And I mean, these devices are important, but some of the indications are very controversial. So I don't know what is doing EACTS and what are doing different societies to fight this and trying to be more transparent.
I have quite a strong views on that, Matteo, and thank you so much for the question. First, what we are doing and what we have to do, as Michael was saying, we have to educate. We have to educate surgeons to look into the small print, know about what outcome variables matter, how to analyze them, how to evaluate them, how to blind researchers in the trials, etc. And you mentioned the European Heart Journal, and Victor mentioned it as well. Do you know why the European Heart Journal has such a high impact factor? Well, this is mainly because of all the guidelines and all the position papers and all the statements that they write. You know, those statements, those guidelines are cited so often that brings the whole impact factor up very easily. And that's part of the whole system, because they have that private interest that they publish all those guidelines and position statements for them to have higher impact factor. And it's all part of the same problem. And we have to fight them. We have to fight. We are all involved in that. You know, if you are asked to be involved in a task force to write a position statement on the treatment of tricuspid insufficiency by the European Association, you will sign up for it, because your name will come up on European Heart Journal, and you have an interest in doing that, which is, I think, is right. And you know, many of these statements are okay, but I think there are far too many of them, and probably some organizations are abusing on them. But we as surgeons and physicians promote that, because that's in favor of our own interest. But as I said, I think education and educate surgeons on how to do objective, trying to avoid as much as possible those conflicts of interest and try to manage them as much as we can, and look into the small print of trials and be able to take our own conclusions after reading the actual data, not the abstract. You know, we need to look at the actual data, and we have to teach that. And education is, I think, is the main answer to this.
Matteo, I think maybe we should wrap it up in the interest of time. We've taken enough of Rafa and Victor's time, but maybe I can, on behalf of the residents that are online and myself, I certainly learned a lot. Thank you very much, Victor, Rafa, for taking the time, and we look forward to seeing you in person one of these days.
Well, thank you, Mateus and Michael and everyone else. I'm delighted to be here, and you know, been talking to you all is fantastic. So thank you so much for the invitation.
Thank you very much for the invitation. Thank you, Matteo. And it's an honor to be in front of all of you and to receive your words, Dr. Burgos. So I join to that hopefulness of joining in the future in person as well.
Okay, take care.
Thank you. Bye-bye.
Thank you. Have a good evening.
Bye.